Good morning. My name is Patrick Green. I'm a family physician in a semi-rural county, Tooele, Utah, a little bit west of Salt Lake City. I have a private practice there that I started about 13 years ago. And from the very beginning, even before I started that practice, have been treating substance use disorders, primarily opiate use disorder, along with everything else that goes with primary care. I don't know if there's anything else too interesting about me. The family practice has gone very well, and then this summer we added methadone treatment to the services that we offer, which has been super exciting. A learning experience and changed my view on methadone. I had been the medical director for a methadone clinic about 15 years ago, and I'm having a much better experience with it this time. And so if you have any questions about implementing methadone, using methadone, or other medicines or treatments that we use for opiate use disorder or other substance use disorders, I really hope that you'll stop me. My favorite thing would be just to walk through the auditorium and field questions and then talk about them as a group. I think it'll be much more enlightening and exciting than the slides that I've prepared for you. So if we go off topic, that's wonderful. I hope that happens. If not, I will bore you with some numbers and examples of how different substances behave in the human body and how that pertains to substance use disorders and the treatment of substance use disorders. So before I even get started, I just want to say it's wonderful to see so many interests represented in our crowd. I find it very similar to Tooele County, where we have county representatives, individual representatives, healthcare representatives. 10 years ago that was not the case, and it was a totally different environment and attitude toward the treatment of substance use disorders. This is a very exciting time. I think we've come a long way, not only with the medications that we use to treat opiate use disorder and the therapies that we use, but it's wonderful that we are getting better at starting treatment as quickly as possible. I hope that it's the same here, but at home, almost any setting, if somebody's ready to start treatment, we can start medications in the emergency room of our community hospital, private clinics, public clinics, and even now the jail in Tooele County. So it's wonderful that instead of people getting a lecture and sent on their way, we're initiating treatment as early as possible. You can imagine that when you need help, you're willing to accept help, and you're feeling horrible with symptoms of withdrawal. If somebody can't provide that help pretty quickly, you'll find another way around it, and we've missed that opportunity to intervene in people's lives, and that costs lives. So I hope that everybody, whatever your role is, looks to finding ways to increase the speed with which we act to stabilize patients so that we can offer them some of those community and therapy services to change the course of their disease. And that really does start with medications. And so I'm excited to talk about that today. It's something that I'm very passionate about. And I'm thrilled that there's so many people here. A little nervous about it. I was expecting a smaller crowd. Most of the things I get to talk about in Tooele, there's maybe 15 people there, but that's okay. So before we start, any questions, any thoughts to get us started talking about medications used in the treatment of opiate use disorder? And if we have time, we might talk a little bit about stimulant use disorders as well. Yeah, I'm coming.
I can just be loud.
Go for it.
So I work at a treatment clinic, and I struggle to understand the difference between how methadone and buprenorphine work in the brain and why one might be better for somebody than another.
Okay, wonderful. So if you couldn't hear because you weren't very loud.
Well, you got closer.
I know.
My brain was like, you don't need to yell at this guy.
That's all right. The question was, From her standpoint, what's your role in your clinic?
I'm a nurse.
Okay, she's a nurse in a clinic that treats substance use disorders, and she's not sure what the difference is between how buprenorphine works, how methadone works, and when you might choose one versus another, and we will definitely talk about that. That is on the boring slides.
Oh, sorry.
Yeah, no, that's okay. I want to make sure we're covering anything else. Any other questions? Anything that somebody wants to get out of today's discussion?
I'm just curious what brought you to this field.
When I went through my residency, I'm sorry, if you couldn't hear her, she was curious what brought me to this field. And when I went through training, the final part of my medical training, it was at the tail end of the prescribed opioid problem, right, the oxycodone days. And our clinic, because it was a training clinic, I think inherited a lot of those patients. And we were just switching over from saying, pain is another vital sign and we got to give you as much as you need to be out of pain, to the next day saying, you're addicted to oxycodone and a horrible person, good luck. And I don't know, our clinic had hundreds of patients that were in that bind. And I didn't want to send them on their way. I didn't want to do nothing. And so first we started, tapering pain medications. That's wrought with difficulties. And so one of the physicians that had gone through training ahead of me was using Suboxone in private practice, which is one of the buprenorphine products. And through talking with him, learned a little bit more about it. Got a job as the medical director at a methadone clinic. And then just my experience working in the hospital, in the clinic, in some urgent cares, there was such a need. And they were patients, clients were treated so poorly for what was obviously a disease that had grown beyond bad decisions. And resources were hard to come by. Getting them paid for was almost impossible. And with buprenorphine, which can be prescribed in a primary care clinic, most of those barriers went away. And so I just kind of fell into that. When I was ready to start my own practice, a doctor in Tooele was leaving, who had been prescribing buprenorphine products, and just kind of sent all of his patients my way. So I opened my practice there. And it was just a really series of fortuitous events and some passion for trying to help people that others were ignoring. Yes?
So I'm interested if you're exploring or looking at the connection with the gut microbiome and substance use disorders.
So the question was, am I exploring or looking at the connection between your gut microbiome and substance use disorders? Personally, no. But I do stress nutrition with all of the patients that I'm working with. It doesn't matter what your chronic disease is, you're going to do better, you're going to feel better, and you're going to get better more quickly if you focus on nutrition. So hopefully along with that we improve the biome. Did I miss a hand over here?
So I believe in Matt. I love Matt. Matt saved my life, right? So I totally believe in medical assisted treatment. But I'm wondering, so I found that and have heard that there's some problems when someone wants to get off Matt. Are you also just as willing to help them step down off Matt? Like on a Vivitrol or whatever?
Yeah, so the question was, strong praise for medication assisted treatment.
Let's go!
But do I help people when they feel like they're done with the medication assistance? Absolutely. When I was at a methadone clinic previously, probably my biggest problem was I felt like they were holding patients hostage and that they were getting them on such high doses without any assistance to ever change that if they decided. And so my philosophy is, and the current treatment guidelines are, there doesn't have to be an end to medication-assisted treatment. If you feel like you need that assistance and you're doing well with the medication, I'm more than happy to continue it. If you change your mind, I'm thrilled to death to try and help you change your medication. And we'll talk a little bit about extended release injection of buprenorphine, which has made that a lot easier. But yes, I'm absolutely willing to help people. And we start from day one when we talk about medications that they can choose from, the pros and cons, when they decide what medicine they want to try, taking into account future decisions. And that can play a big role with some patients, especially with methadone, if doses are getting very high. It can make it difficult later. Okay.
I have two questions. One was from yesterday. Someone brought up the difference between men and women metabolizing opioids. And I wonder if you're going to touch on that at all today and how that's making impacts on the treatment.
Yeah, so the question was difference between men and women when it comes to metabolism of opioids. And we can broaden that quite a bit because not only is there a difference between men and women, but there's a difference between men, women, pregnant women, and individuals based on their genetic metabolic traits. And so I didn't spend a lot of time preparing slides for that, but in reality, when it comes to treatment, most of the time, we're tailoring medications and medication doses to outcomes and patient feedback. And so if the person next to you metabolizes a medication more quickly than you, they may end up on a higher dose than you to achieve the same result. And so unless there are significant barriers, then it's not too big of an issue. There are some genetic tests that we can get that look at your metabolic pathways and can guide us on medication selection, not just for opioids used for pain treatment or the treatment of opiate use disorder, but also a lot of other medications for mood disorders, cardiac disorders. So we are paying much closer attention to that than we ever have before. Yeah, if we, towards the end, if we have time, we can talk about upcoming treatment options and off-label use of medications that we use for stimulant use disorders, which is definitely difficult. We have some good options that are FDA approved for the treatment of opiate use disorder. Currently, we don't have any options that are wonderful or approved for methamphetamine or other stimulant use disorders. Shoot.
So where I live is very rural, there's a lot of country folks, and they don't know how to rest, so they drink about it, doesn't feel properly, they keep working, they're in a lot of pain. So they tend to get on some medications and things and stay on them and do that high doses. And there's obviously an addiction in there in their body from being on these medications. But they can't get off of them either because they still have to run the farm or whatever. Do you guys work with anything like that?
Yes, so the question was, what do we do to help patients who have chronic pain from an injury or other illness, who've started taking pain medications and either won't, can't, or choose not to stop taking those pain medications, and whether there's some overlap of addiction or substance use disorder for those patients, and do I treat that? And the answer is yes. I don't think that you can be in general practice without taking care of chronic pain. It's probably one of the most common complaints that we see in clinic. And there still is a lot of holdover from overprescribing in the past. So patients that you see who are on very high doses of pain medications. My approach to that is usually I always start with trusting the patient. If the patient has a reason to be in pain and needs treatment, we start there. Most of the time these days, they're already on some medications. And so rather than changing those medications, I spend a lot of time trying to get historical records and getting to know my patients. And once we've established a good relationship and I feel like they trust me, we can start to talk more about chronic pain and chronic pain medicines. A lot of times, if you've been on pain medicines for a long period of time, it makes pain worse, and things that don't usually hurt very bad start to hurt very bad. That's real to them, right? That's their body's adaptation to having pain medicines around all of the time. If they're on top of it, they're doing everything they can to treat the pain other than just pain medicines, and that may be physical therapy, interventional treatments, non-narcotic medications, mental health therapy. We have a long list of things that can help. We can continue their medication. I watch closely for signs of substance use disorder, but oddly enough, if you take patients with chronic pain as a population, the incidence of substance use disorder is lower than a lot of other populations, so it's not quite as risky as you would think. And then from there, we're always trying to achieve the lowest dose that treats the symptoms. And if they're willing, I'll often switch them to buprenorphine or Suboxone, which works quite well for chronic pain, but doesn't tend to have as much tolerance or escalating doses as some of the other medicines. So yeah, we deal with it a lot. Yes?
I'm going to use my stepson as an example. I started my journey in healthcare from mental health, which is his issue was he started self-medicating because of extreme paranoia and taking cures. So he self-medicated, it took care of the paranoia and the voices. Then he'd go into a program. They wouldn't recognize why he was self-medicated because they were just treating the addiction. And he'd go to the program, he'd do really well, he'd start being sober. The voices, the paranoia would act up, and then he would start doing things that weren't appropriate. He'd get kicked out of the program. Then, because he was paranoid and hearing voices, he'd start using again, self-medicating, and it was just the cycle over and over and over again. And it wasn't that he was necessarily addicted, which I'm sure that was an issue too, but he was self-medicating. And it wasn't until recently, because he finally got into a program, that they recognized what the underlying issue was. What are they doing for that? Because I'm sure there's a lot of people there out there because mental health is an issue, because it being treated. What are they doing for those people that mental health is an underlying issue? It's not necessarily the addiction that's the underlying issue, but once they get dry, they're hearing voices, or they're denying that they're hearing voices, and they don't understand it.
Sure. So the question is, what are we doing to address mental health disease when it goes along with substance use? With example of somebody who was in and out of treatment which seemed to fail because nobody was addressing their mental health issues. And I can tell you what we do and what everybody should be doing. I like to look as far back as I possibly can because substance use disorders and the risk for developing them start at birth with the genetics that you inherit. And then you start to tally up these risk factors as you move through life. Some of those might be chronic pain, mental health, trauma. If we don't uncover those and address those, recovery and treatment is less likely to work. And our goal is to increase patients' chances of success when it comes to meeting their goals. And so we do a lot of mental health screening and then diagnosis and treatment or referral when it's needed to make sure we're trying to treat mental health issues, which are very common in substance use disorder patients as a population. The chances that somebody has anxiety, depression, bipolar disorder, ADHD, or some other mental health diagnosis once they're in your clinic with a substance use disorder is extremely high. So we look closely for it and expect to find it, and if not, we look deeper and make sure that if it's there, we try to address it. Yes?
I work in a detox facility where it's not always in a timely manner that we can get our clients to say the Bridge program or the Compass program because they're closed or whatever. Do you have any suggestions for what we as recovery assistants could suggest to the clients to help their withdrawal until they could get to a place where they could obtain MAT?
Yeah, so the question is, what can we do for our clients who are in a position and need treatment when it takes a long time to get somebody in treatment or to a doctor to start medications? I think your best bet is to try and develop relationships with certain providers. I know in Tooele, anyone seen in the emergency room or other centers, they can walk in my door the next morning when I get there at 9 a.m. and I'll fit that in. And so I think you probably could find some people with quicker wait times. I think, and the University of Utah folks could probably better answer this, but I think that they can start the Bridge program in their emergency room, and I'm guessing they have another rapid intake access so that everyone's not funneled through the ER.
Well, I work for the VOA Center for Women and Children, and a lot of our women are coming in the middle of the night, and they're already in really severe withdrawal symptoms. So
does your program have a prescribing provider?
We do. We send them to Project Reality. We send them to Compass. We send them to the Bridge program. Just sometimes it's like we already have a client scheduled to go to Project or something like that. So sometimes it takes, even if it's a few hours to a day, day and a half. And meanwhile, we're watching these clients that are having the hardest of times. And if there was something that I could suggest to them, like I already suggest, take a hot bath. Would you like a Benadryl? Things like that. Are there things that I'm not doing yet that I might be able to do that could help?
No, I think in that instance where you're trying to take care of patients in a facility before they have a chance to see the prescribing provider, you're stuck focusing on treating symptoms. Yeah. And so you can use over-the-counter medications to treat pain, nausea, vomiting, insomnia. You might be able to talk to your prescribing provider about standing orders for non-controlled substances that can limit withdrawal symptoms, but that would take more training and effort on the staff's part. Right. And then I think you have to make sure that you have a way to get those patients in front of a provider first thing in the morning. Right. Because you can make it through the night, but much longer than a day, and we know those patients are going to leave. They're not going to stay. So that's a tough spot. Yeah. I'll try to get through some of these slides. Most of them we'll skip through pretty quick so that we can answer some of the questions about how medications work in the treatment of opiate use disorder. But at any time, feel free to raise your hand or stand up and flag me down if you have other questions. Thank you for asking the questions you do have. I think we all get a lot more out of it if I know what you need. And I'll try to continue to focus on those things, but if you have any other questions, just stand up and yell. Objectives, I really hope that we just have a good discussion about how opiates work, both prescribed, those that are misused or illicit, and then the ones that we use to treat opiate use disorder. If we get through that, I think we did good. When it comes to pharmacology, we kind of break it down to how does the medicine work and what's the effect that the body experiences when it works, and the timing or what happens with that medication while it's in the body. And so we break that down to dynamics and kinetics. The rest of the slides will have a lot less big words on them. For opiates, the primary mechanism of action, whether we're talking about prescribed medications for pain, illicitly used substances like heroin, or some of the medicines that we use to treat opiate use disorder, they act on an opiate receptor, primarily what we call the mu-opiate receptor, which is located throughout the central nervous system and body. Most of the effects that we focus on are within the brain. And we won't get into too many more details, but it's the binding of that substance to that receptor that produces euphoria, decreases pain, reduces anxiety, but then also causes some of the negative effects like respiratory depression and overdose, constipation, nausea, flushing, itching, and some of the negative reactions. Some of those are also caused by metabolites. After your body starts to break down that substance, those secondary chemicals can bind to receptors and cause some negative effects as well. And that's where differences in metabolism can play a big role. If your genetic makeup predisposes you to the negative effects of a substance versus the positive effects, you're much less likely to develop a substance use disorder for that substance, because to you, it's not good. You don't like it. You hate it. And if we have time, we can talk a little bit about how we're looking at that as a possible treatment option for some substance use disorders. So we'll go through some common medications, illicit substances, and then the medicines that we use to treat them. And I really wanted to just focus on what do you need to know when it comes to understanding or treating patients. We could spend all day talking about how receptors work and some of the finer points of pharmacology, but I tried to keep it pretty shallow. So if you have more questions, just shout out. Morphine is probably the best known opiate, and that's kind of the base molecule where a lot of our other medications or substances have sprung from. It's what we call a full mu receptor agonist, meaning when it attaches to that receptor, it has 100% activity. It's not the best when it comes to providing to patients. So it has decent availability if we give it through an IV or an injection. Taking it by mouth, not so good. You only get about 25% of the medicine that you take by mouth into your system. It takes a little while to start working. The time to peak effect, if you take it by mouth, is about an hour, or about 10 minutes if it was as an injection. And then we get it out of our system fairly quickly. The half-life is 2 hours. You can estimate the time it takes to clear a medicine from the body. It's about 4 half-lives. So if you get a dose of morphine, about 8 hours later, that dose is out of your system as far as effect goes. And then once you've taken it, your body breaks it down through the liver, and then those byproducts are largely excreted in your urine. Oxycodone, similar to morphine, it's a full receptor agonist. However, it's very available if you take it by mouth. So where the morphine, you get 25% of what you swallowed, with oxycodone you get about 70%. It takes about the same time to work if you take it orally, and it lasts a little bit longer. It's also metabolized by the liver and excreted by the kidneys. And the metabolism, I think, is important because, especially for patients, we have to take into account how their body's going to clear that substance if they have liver disease, cirrhosis, hepatitis C, or other issues. Not quite as potent as morphine. It takes about 1.5 milligrams of oxycodone to equal 1 milligram of morphine. So heroin, Similar to those medicines, it's a full receptor agonist. It has very high availability when injected or inhaled, but poor oral availability. When we talk more about treatment, we'll talk a little bit about what predisposes a substance to be a good drug of abuse versus what makes it a good option for treatment. Primarily, how quickly does it act? And so heroin acts much more quickly than morphine or oxycodone, and it has a significantly shorter half-life. So after being exposed to heroin, hour and a half, 2 hours later, it's pretty much out of your system. And if you're in the cycle of tolerance, dependence, withdrawal, that makes a big difference, because as soon as it's out of your system or on its way out of your system, you start to feel the effects of withdrawal, which is miserable. Fentanyl, which I don't know how it is here, but most of my patients right now can't find heroin. It's all fentanyl, which is terrifying. It's significantly more potent than heroin and morphine. It has pretty good availability if you're smoking it. And so most of the patients that I see are smoking it. It has relatively poor availability if you take it by mouth. It's very rapid acting, and it's relatively quickly eliminated from the body. And similar to the other ones that we've looked at, it's largely metabolized by the liver. Okay, so we'll start talking a little bit about medications for treatment. And so if I don't answer your question about the differences between methadone and buprenorphine and when to choose one versus the other, stop me. Methadone was the first medication that was approved for the treatment of opiate use disorder. It works very well because it's a full receptor agonist. And so the withdrawal symptoms that you experience, the cravings, and some of the other issues if you're trying to stop using heroin or fentanyl or other illicit opiates, we can meet that need pretty easily with methadone. It has good oral absorption, which makes it nice because then we can give it to you in clinic as a liquid or a tablet. We don't have to use an injection. It reaches the central nervous system, which is important because that's the primary location of action that we're targeting. It's slow acting. It takes a couple hours before you reach peak effect, which is okay. And importantly, it has a very long duration. So its half-life is somewhere between 24 to 36 hours. And so, like we talked about earlier, if you're clearing a substance from your system quickly and you're on this roller coaster of dosing and withdrawal, we can stabilize that with medications like methadone that have a long half-life. We can give it to you usually once a day, and you only have to take it once a day without worrying about getting sick. It's metabolized by the liver and then excreted in our GI tract, it has about a 10-to-1 equivalency with morphine. Buprenorphine is the first one on our list that's not a full receptor agonist. So we call it a partial or a mixed opiate receptor agonist. And importantly, it has a very high attraction to that receptor, but it has, because of its partial activity, it doesn't stimulate that receptor nearly as strongly as the full receptor agonists. And those characteristics set it apart from a lot of other options and can make it a wonderful treatment option. So because of that, we can still control withdrawal symptoms and reduce cravings. It counteracts the reinforcing effects of other substances. So if you're taking your medication at an appropriate dose the way that you're supposed to, it reduces the euphoria and reinforcing symptoms that you would normally get with substance use. Because it has less activity at the receptor, it's not as likely to cause those symptoms of euphoria, so it's not typically misused. There are some situations where it can be, but in large part, it's not that way, which is nice because everybody's question coming into clinic, especially if it's family members, is aren't you just replacing one thing with another? And it's nice to be able to tell them they can take too much of this and they're not going to get intoxicated. The safety profile, because of that lower activity, is also really nice. So the medication peaks at about 24 milligrams. Above that, there's no more activity. With the full agonists, the more you take, the more it does until eventually you'll die. With buprenorphine, you can take up to 24 milligrams. Taking more doesn't increase activity. By the time we get there, all of your opiate receptors are already bound with the medication, and they're getting the maximum stimulation that they can, and it's much safer. That can be an issue if they're mixing it with other substances, specifically other sedatives like benzodiazepines. Unlike methadone, it has poor oral bioavailability, so you can't swallow it. If you do, it doesn't do much. So it's primarily given as a sublingual tablet or film that you put in your mouth and you absorb through the tissue in your mouth. There's a newer version, which is a extended release injection that we'll talk a little bit about. And it's relatively slow acting if we compare it to substances of abuse, but it also lasts a very long time. So oftentimes, and in other countries, it's often dosed less than daily. There's a lot of clinics in Europe that dose it 3 times a week because it stays in your system so long. And then similar to the other medications, it's metabolized primarily by your liver. Sublocade is the brand name of the depot injection shot, and it builds on those properties and offers what I think are a few more really wonderful attributes. Primarily, we give the shot once a month, and so we don't have to take it every day. Patients don't like to take it every day. It does not taste very good. We can still get the same benefit of controlling withdrawal symptoms, reducing cravings, blocking the euphoria and reinforcing effects of other opiates with a once-a-month treatment. It stays in your system after we've done a series of injections for up to another 12 months. I've had some patients they still have a positive urine test for buprenorphine 14 months after we've stopped giving them injections. And it's that long duration where your body's just slowly metabolizing and using the medication that was stored up through the series of injections that make it so effective. Because when we stop, there's no withdrawal. There's no detox. There's no need to slowly taper off the medicine most of the time. I think we've probably seen a few hundred patients that we've treated with Sublocade at this point, and I've had 2 bounce back who were experiencing withdrawal symptoms after we stopped their injections. So it's fantastic. And in our jail now in Tooele, if patients are there with opiate withdrawal and they're there long enough to stabilize on oral buprenorphine, they will start them on Sublocade before they leave the jail, which is fantastic because in the past we did nothing except for lecture them while they writhe in the corner of their jail cell and then send them on their way. And then we started offering some treatments for symptoms, and then some started using buprenorphine, and then some Vivitrol, which we'll talk about, and now Sublocade, which is wonderful because patients have a window where they leave incarceration and they have a month or more to get to a clinic to continue their treatment, and in the meantime, we're blocking the effect of the substances that they were using before they were incarcerated. And that's especially important when we look at risk for overdose. If somebody's been in a controlled environment and not using to the extent they were before that, and then they're released, they often go back to high-dose use, and their tolerance has decreased, and their risk for overdose is quite high. And so we can achieve a lot of benefits by using medications like Sublocade and Vivitrol when anybody's leaving a long-term controlled environment, whether it's incarceration or not. So that's buprenorphine in a nutshell. Some differences between the compounds. You can get plain buprenorphine. You can get buprenorphine with naloxone added. I often have patients coming in saying, just give me the buprenorphine. I don't want the risk of what we call precipitated withdrawal. And there's some confusion about the naloxone additive causing the withdrawal, when in reality, it's the buprenorphine affinity for the receptor that puts them at risk for precipitated withdrawal. So if you have opiates in your system and you're not experiencing withdrawal and you take buprenorphine, that high affinity brushes them out of the way, binds to the receptor, but it does not stimulate the receptor enough, and you develop rapid, significant withdrawal, similar to if you were exposed to Narcan or some of the other opioid antagonists. We get around that usually by waiting in between your last opiate exposure and starting buprenorphine, and like you, focusing on symptom management in the meantime. But there's some other ways that we can get around that as well. I think the biggest drawback to buprenorphine for me most recently is trying to overcome the tolerance some patients have who are using extremely high amounts of fentanyl. It's a very potent, full opioid agonist, and buprenorphine is not always strong enough. If you're in a controlled environment where you can treat withdrawal symptoms, monitor the patient, and help them transition, I think it can be done much easier than in clinic. But a lot of times, we may start trying to get a patient transitioned to buprenorphine from fentanyl and they disappear. They're just not getting to where they need quick enough, and they feel bad long enough, and they take matters into their own hands and fix things the way they know how. And so in those instances, methadone can be a very powerful tool because it has that full opioid agonist, and so I know we can meet their tolerance requirement. It's also difficult because of the restrictions placed on methadone. We can only start at a certain dose and increase every so often, so there's still a transition period, but it's a little easier to get patients through that if they have an extremely high tolerance for fentanyl. The last medication that's approved for treatment of opiate use disorder is naltrexone. It comes under the name brand of Vivitrol. You can get it as a tablet or a monthly injection, and it's the opposite of those other medications. It's what we call a full antagonist, meaning it binds to the receptor, it blocks the receptor, but it has no activity at the receptor. And so if you have opioids in your system and you take that, you definitely will get precipitated withdrawal. But if you don't have opiates in your system, we can use that to cover those receptors, reduce some of the symptoms that go along with chronic opiate use disorder, and primarily protect you from relapsing disease because those receptors are blocked. Interestingly, we use it also for alcohol use disorder, and there's some promise in its use in conjunction with other medications for stimulant use disorder. There's even some animal studies in the veterinary field showing that it can reduce self-harming behavior in animals who are seeking a internal endorphin release. So it does do quite well at reducing, reinforcing behaviors and not only substance but behavioral addiction. So it's kind of a jack of all trades, but today we'll focus primarily on the opioid use disorder. I like the injection, same thing, it's a monthly injection. You can't decide to stop taking it for the weekend and get back it on the next week. If your spouse is in there with me, they get a significant amount of relief just watching you get that shot every month. So it's a great medicine. The problem is you cannot have opiates in your system when you start it. And the prescribing guideline from the manufacturer is 14 days opiate free. I can't get somebody 14 days opiate free very often in my outpatient practice. So I think its use is wonderful if you're in a treatment center, if you're coming out of incarceration and you've already gone through detox. or if you've been doing well in recovery and decide you need some support, but you don't want to develop tolerance and dependence on buprenorphine or methadone. So it can be a very wonderful tool, but in the acute scenario where patients are experiencing withdrawal, it's a little bit harder to use, in my experience. So if we talk about those medications and substances of abuse, the characteristics that favor misuse are high bioavailability. You've got to be able to get the substance in your brain. So substances that are already highly available are good, but people know how to improve it. And so that's where we see a lot of patients either smoking or injecting substances because it increases the availability. Not only do you want to get as much of it in your system as possible, but the euphoric effects and reward come from rapid action in the brain. And so it needs to rapidly get into your central nervous system. And there's a barrier there that keeps some things in and some things out. And so certain substances can cross that barrier easier. And a lot of people have figured out how to alter other substances to help them cross that barrier easier. And then the short half-life, or the rapid clearance of the substance, because that rapid clearance of a substance you're dependent on is what leads to those withdrawal symptoms. If it stays in your system for days and days and days, it's a very gradual decrease, and so the symptoms are gradual and less severe. If it clears quickly, they come on abruptly and they're very severe, and so we see this roller coaster of repeated use throughout the day. And so those characteristics in particular, if we flip back through the slides, you would notice heroin, fentanyl, oxycodone meet those criteria. If we talk about characteristics that favor good treatment options, we want good oral bioavailability. It's much easier to give people a medicine if they can take it by mouth. It doesn't mean we can't get around that, but it's much easier. And then we want a long half-life. We want that medicine to stay in their system longer. The serum level is stable. The risk for withdrawal symptoms is less. And the window for relapsing substance use is less. And then we want it to be safe, and we want it to be well tolerated. And so with those criteria, methadone, buprenorphine, and Vivitrol have been wonderful. So questions now about opioids. Yes?
Earlier you talked about clients that might have a window of abstinence. One of the things that we see at the Odyssey House, we take a lot of clients from jail for prison. And they have months sometimes without any opioid use. However, what got them into that situation was based on opioid use, right, substance use. And so when they come to our program, they're wanting to get back on some sort of medication-assisted treatment. What is your view of that? And I know that's kind of vague, but we have often discussions where we're not sure if it's appropriate because the clients are maybe drug-seeking behavior, right? But at the same time, we know that coming out of an incarcerated setting and coming into a residential setting can trigger certain things, certain behaviors have not been addressed in that setting. So we're wanting to provide, comfort, for lack of better words.
So if you couldn't hear him, his question was, what's my view on starting a patient back on buprenorphine or methadone where they will become physically dependent on that medication? They are in a situation where they may get some rewarding effects from either medicine if they are coming out of a controlled environment without substance use for several months. And so my my view is that's an emergency. I mean, this is a lot of times lights and sirens emergency. You have a patient who's telling you they're at risk for recurrent substance use. They're in a state of low tolerance. We know they have the tools they need to find and use substances because they've done it in the past. And they want the support of medication to continue their recovery now that they're out of that controlled environment. And so I talked to them about it. The current guidelines are, it's their choice, which medication they feel like would best meet their needs. That doesn't mean you give them whatever they want, but I think it does mean that you value and prioritize their decision. And I try to make sure they understand there's options. We can use antagonists and provide the support that they need without any risk of physical dependence, intoxication, or future need of detox, right, with naltrexone. And we can do that as an oral pill or the monthly injection. And I think that's a great place to use that medication. And so I strongly encourage that. However, if they've tried it before and failed, or there's some other reason that they don't want to use that medication, I would not hesitate to resume treatment with buprenorphine. It's a little bit harder with methadone given the federal criteria, but depending on which environment they're coming out of, if it was incarceration, then we could restart them on methadone. I'm very dose conscious, and so I start at much lower doses than I would if I had somebody in acute withdrawal. I see them frequently and check in with them a lot. And I find most of my patients I know very well. I've seen them on and off, either for primary care or substance use disorder for years. I was surprised how many patients I found again once we started our methadone practice, because they had failed buprenorphine treatment and disappeared, and I didn't know what happened to them, and then I got them back when we had the methadone practice. And so I would not hesitate at all. Most of the time I find they're not drug seeking, they are at risk and scared. And so if you can meet their need with naltrexone and therapy, that's great. And if that's not working, you can change to another medicine. But they need to know what the risks and benefits are and the requirements, because it's not easy to be on those medications. There's frequent visits, there's frequent urine drug testing, there's sometimes required therapy, although I think for the most part we're moving away from required therapy. It should be encouraged therapy now. And you're at the whim of the prescription, right? For most of my patients who get a week prescription at a time, that makes it really hard if you want to go out of town, or if there's some other urgency.
Yeah, most of these clients that I'm referring to are coming into our residential treatment setting.
Yeah.
So it becomes a debate about are they being honest? Are they drug seeking? What is it that we can do in order to increase the probability of success? Obviously, we don't want to put them in an uncomfortable situation. We don't always know if they're actually using while they're inside the incarcerated setting as well. So Vivitrol may not be an option because maybe they don't want to admit the fact that they were doing things that could add more time or be a violation for their sentence. So it creates all these different factors and barriers, and so it's tricky. And so I appreciate your response.
Yeah.
I'm not a provider, but we deal with this on a regular basis.
Oh, absolutely. And it is tricky. I like to think of it about, if you came to see me, or if you were in the hospital for high blood pressure or diabetes, the first recommendation is lifestyle modifications, right? You need to eat less salt, you need to reduce your alcohol intake, and go running every day. Well, what if that doesn't work? Okay, we're going to start a medication. So especially if they're in your residential treatment program, if they're not responding appropriately to non-medication assisted treatment, start the treatment. I mean, they can leave whenever they want.
True.
And I have a lot of patients that leave treatment centers, Odyssey House and others, in large part because their needs are not getting met. And I don't think it was their desire for controlled substances that wasn't getting met. I think it was their stability. And if you look at substance use disorders in the disease frame of reference, they have their brain is physically and functionally changed. It is not behaving the same as a normal brain. And you may not be able to stabilize that without the use of medication-assisted treatment. And that's okay. But I think you watch the dose, you watch the behavior, you make sure everybody knows what's happening. All right, I have 8 minutes. So the question was, am I having an issue with patients not trusting medications? Vaccines, yes. A lot of other medications, not so much. But I think it depends on what medicine you're asking them to accept, right? If you have a patient who has been exposed to opiates and you want them to accept Narcan, that's a strong no.
No, it's Benadryl.
Okay.
And we're like, you are just injecting something that you have no idea where it came from, and you don't want Benadryl.
Yeah, I don't run into that as much, but it does bring up, I think, something that's up and coming, which I am excited about. She had mentioned she was an EMT, and a big problem with responding to calls for substance use related issues is they don't want to go to the hospital because they're worried about law enforcement bills or other things. So if you had responded to an overdose and revived them with Narcan and now they're sick, again, that's a very vulnerable, dangerous situation. And there are some counties in the country that are starting to allow EMTs and ambulances to provide buprenorphine to those patients so they have an option, right? They have a window where, okay, there was a hard stop on whatever they were using because they were just resuscitated with an antagonist. We know they're going to be in withdrawal and have to do something about it. Let's just give them some buprenorphine and get them in with an appropriate provider today or tomorrow to use that as an opportunity to intervene. And so in Tooele, we've been talking with the medical director for our EMS services, and I'm imagining this discussion's happening across the state, but I think it's a wonderful idea.
We usually give them, if they refuse, we give them the Narcan that we give them and another Narcan because it only lasts a certain amount of time.
Oh yeah, everybody gets Narcan. Hand that out this Halloween. Yeah, and that brings up the primary difficulty in treatment of patients with substance use disorders is we started the process with so many barriers to treatment. We made it almost impossible for someone who is willing to treat their disease to treat their disease. And so anything we can do to break down or get rid of those barriers, like providing medications in the field or in the emergency room or in the jail or in your family practice clinic, we should be doing that. I think that's really where our focus should be. And then things should be approached with the same empathy and compassion that we have for any other chronic illness. So if you take nothing else away from today, I think it's medications are rad, treat people like people, and intervene quickly. If you're starting medications appropriately, you don't need to worry about the behavior so much. That is still the #1 evidence-based treatment for opiate use disorder.
Yeah, and the issue is that we've had that some of our providers are afraid my list, like, is growing of providing this
Sure.
medication on this database and my license, and it goes into that, right? Those types of discussions. And we're all for it.
Yeah, reassure them the risk is low. I mean, if you're in this field, whether it's where I'm at or where you're at, your providers are at the top of the state controlled substance database, and they come to visit me every once in a while for questions about prescribing. Super supportive. If you're doing what's right for the patient, you're gonna be okay. Never once has anything come of our visits other than keep up the good work. So I don't think they need to worry about that, especially in a controlled environment. Thank you.